Hi, Dr. Rosu.
Hello. Hey, Hiba, how are you?
I'm well. How are you?
Good, good, good. Let me see. It's hopefully this should work better. Hey, do you guys have like, um, do you do questions and how do you interact on this thing? But if there are any questions, do other participants, do the residents like typed answers or do they speak up? How do you do this?
Any or all of the above.
Okay,
We'll let them unmute themselves. Some people like type it into the chat box. It's really,
okay.
some people are like, I don't know, at home doing other things, etc. So
Gotcha. Yeah,
don't leave
I know how that goes. Yeah. All
it.
right. So, let's just give it a few more minutes before we,
Yeah, yeah.
yeah. So, all right.
We've had stragglers lately.
Yeah, yeah. Maybe I'll be back by 6:05 or something. All right. I just gotta go sign a couple of notes.
Yeah, yeah. Sounds good.
Hello. Hey, good evening, everyone. Should we get started?
Sure, I think we can, and then if people join in, that's more than fine.
Okay. All right. Good enough. So I apologize for last week's fiasco. I think I need a new laptop. But anyway, so hopefully it should be smooth sailing today. I'm not going to start from the beginning. Let's just touch on the more important points. So physical exam, as kind of we touched on last time, it's let me get this going here. So I'm just going to go with the bullet points here, just word associations. So the first part, in terms of cardiac exams, so you'll have this whole description of heart sounds, just basic physiology. As you know, the left-sided valves are louder. The aortic valve is the loudest. It closes first. And so if it is delayed, usually a delayed A2, if you hear that, it's left bundle branch block or a reverse split. Delayed P2 on the other hand, is the right bundle branch block, because in RBBB, the right side gets depolarized later. So that's kind of the basic physiology. In terms of exam questions, if you hear a loud P2, it's usually pulmonary hypertension, and a soft P2 is pulmonic stenosis, which I don't think they'll quiz you on IM boards. On the left side, A2, a soft or a single second heart sound or absent second heart sound is almost always aortic stenosis. Loud A2 typically is systemic hypertension. The higher aortic pressures just kind of snap on the valve back. So just a few more facts on it. So if you hear a opening snap or a loud S1, that's usually mitral stenosis. And the soft S1 is severe mitral stenosis, where the valve is really not functioning at all, advanced, or in atrial fibrillation, there is no atrial contraction. So moving on, splitting. So, it's very hard to clinically hear splitting in most of our patients because they're obese and have COPD. But on the exam, it comes up quite a bit. So the basic physiology is the right-sided valves open earlier and they close later because it's a low-pressure system. Therefore, A2 comes first, P2 comes second. So that's basic physiology. So if you see persistent or widened splitting, where the gap between the two sounds are wider, it's usually either a right bundle branch block or pulmonary hypertension. A fixed splitting, that's a board favorite. I think you all know it's ASD. And a paradoxical split, where it's flipped over, is typically, as you guessed, left bundle branch block or with the pacemaker. So moving on, this is just one slide for location of murmurs. It's a pretty good slide. I think we went over this last time. So basically, anything that's in the second intercostal space to the right of the sternum is aortic stenosis. Left side is pulmonary stenosis. Anything under the clavicle is a PDA, continuous mesentery murmur. The aortic stenosis, as you know, radiates to the up to the neck and to the carotid area. Apex is mitral area. So apical murmur, systolic is mitral regurgitation, and it typically radiates towards the axilla. And if it's the right side of the sternum, it's tricuspid area. I mean, that's all you really need to understand. So lower sternum, right sided tricuspid, apex is or left of the sternum is usually mitral, and upper second intercostal space, right is aortic and left is pulmonic. So maneuvers, you got this just basic, just three of these that you need to remember. Standing up or Valsalva, anything that decreases venous return would decrease volume in the heart. Therefore, all the regurgitant murmurs will become less prominent. With the exception of hypertrophic cardiomyopathy and mitral valve prolapse, both of which worsen. Because if there's a low pressure in the atria, the mitral valve tends to prolapse more. And if there's less volume, the thickened LVOT rubs against each other more. So therefore, those two murmurs worsen. Now, squatting is the opposite. When you squat, all the blood in the legs come back up. So there's increased venous return, increased cardiac output. So it worsens every murmur, exception of Hookham, because with Hookham, more volume means the walls of the LVOT are further apart. So there's not as much murmur. The only place you would hear about a hand grip is if you need to distinguish between mitral valve prolapse and Hookham. And the hand grip, again, it increases the afterload. Therefore, Hookham decreases while mitral valve prolapse increases. Just remember that with hand grip, a murmur that decreases is hypertrophic cardiomyopathy. If it increases, it's mitral. All right, moving on here. So this is just a neat slide showing you what the diastolic murmurs are that you should know. So basically, aortic pulmonic regurgitation and mitral stenosis, while PDA is both diastolic and systolic. Moving on, the systolic murmurs would be the the aortic and pulmonic stenosis murmurs, and at the bottom is mitral and tricuspid regurgitation. In addition, there's Hookham is also a systolic murmur. And then both septal defects are systolic murmurs, because in systole there's increased pressure on the left side, so the blood moves into from left to right. So most of them are systolic murmurs. PDA is a continuous murmur again. Just a few facts for the exam. So anything that's described as a blowing murmur is usually a regurgitant murmur. Anything that's crescendo, decrescendo is going to be aortic stenosis or Hookham. Those are the only two choices. Diastolic rumble is mitral stenosis. Okay. And if you hear anything that's left lower sternal bladder, vibratory, musical, flow dependent, no radiation, so forth, that's Still's murmur, which is a benign normal functional murmur. Okay. In terms of the cardiac cycle, if it's just mid-systolic, it's usually aortic stenosis or Hookham. Pansystolic is always regurgitant. It's usually one of either mitral or tricuspid regurgitation or a septal defect. Okay. Mid-diastolic, early diastolic is usually AI, and mid-diastolic is mitral stenosis. So these are just things to kind of memorize and remember. And continuous murmur is PDA, as we just talked about. So moving on from murmurs to pulse, again, these are just word associations. So bifid pulse or Bispherians pulse is aortic insufficiency as well as Hookham. In Hookham, because there's initial pulse and then there's obstruction, so the cardiac output goes down and then the heart squeezes more. So you have a second pulse. Pulses alterans is, as you know, on CHF. And slow rising or pulsus tordus is aortic stenosis. And pulsus paradoxus is tamponade. It's pretty easy to remember. Let's move on. So, these were actually designed as questions, but I don't know how well we can do that on a Zoom conference. But so let me just read them out so we're not wasting time here. So anytime you see a palpable apical heave, it's from LVH. And if you have RVH, it's a parasternal lift. So typically seen in mitral stenosis. Okay. And friction rub, as you all know, is from constriction or pericarditis, any kind of pericardial inflammation. And pericardial knock is usually typical of a constrictive pericarditis. Okay. So venous pulse, again, there is a few things that you need to know. So as you know, this is a typical venous pulse. A is the A wave happens with atrial contraction. So most of the time for your boards, you'll have an EKG above it. I'll show it in my next slide. So right near the P wave, under the P wave would be the A wave. And C is where the tricuspid valve closes. V is the V wave is passive filling of the ventricle. And you have the two X and Y descents. There are usually about 3 questions that come in relation to the venous pulse. The first one is would be something referring to a Cannon A wave, where the A wave is really tall. That happens when the atrium is contracting against a closed tricuspid valve. So there's clearly AV dissociation. Happens in the 2 conditions. Either there's SVT with, let's say, 2:1 block, then you'll have alternating A waves. Or if there's a VT where the ventricle and or a complete heart block where they're contracting independently, then the atrium ends up contracting against a closed valve, which also happens occasionally with pacemaking as well, pacer as well. So that would be Cannon A wave. The other 2 entities are a prominent Y descent and a prominent X descent, which are seen in constriction and tamponade respectively. So let me show you the next slide. So this would be a typical picture where there's a prominent Y wave. You see a P, you see actually there's this atrial activity, and before that is a Y wave. So that's a P here, and so this is the A, and you see the Y just before the A. That would be, and the K stands for knock, but that would be typically, if you see something going down so much, you'll also have a clinical picture with it. So if it's something acute, then it's probably X wave and tamponade. If it's something more chronic, then it's usually a Y wave and constriction. Okay. So here are some questions. Let's see if we can make this. So sharp irregular Cannon A waves with the white complex tachycardia, usually seen in ventricular tachycardia. Not sure why it's automatically coming on the answer. So these were actual board questions that have come on over the years and various formats. So if you have something similar with the intermittent Cannon A wave with the narrow complex rhythm, then it's usually supraventricular tachycardia. If you have a wide complex rhythm, it's usually ventricular tachycardia. So those are the two usual answers. And steep Y decent is constriction or restriction, and steep X decent is usually tamponade. So moving on. Okay, let's see if we can answer these here. So these are again questions from the boards over the years. So 65-year-old male with a JVP 4 centimeters supine goes up to 10 centimeters while palpating the liver. So what is the diagnosis? You guys could use the chat box or just answer. Perfect. Yeah, CHF, and it's called Kussmaul sign. So I think the options there were, amongst other things, CHF was one of the answers. So 30-year-old woman with a loud S1, a P2 mid-diastolic murmur with pre-systolic accentuation. Perfect. So it's MS. So anytime you see a young woman, especially pregnant with the mid-diastolic murmur, it's usually MS, mitral stenosis. Good, excellent. So 62-year-old African-American male with ESRD presents with acute dyspnea, elevated JVP, clear lungs. EKG shows alternating amplitude changes. So what is the alternating amplitude changes called? And what do you think? That's right, electrical alternates, and they could also have alternating pulses, pericardial, excellent. Yeah, pericardial effusion, and usually a tamponade. And this is pretty typical in ESRD patients. They have uremic pericarditis. So anytime you see someone with shortness of breath and clear lungs, it's either constriction or tamponade. Perfect. So 30-year-old woman with a diastolic rumble and a mid-systolic click. MVP, perfect. So so this is just MVP without regurgitation. If they had a regurgitation, then you'd also have a systolic component. Good. So 18-year-old with palpitations, 2/6 systolic ejection, systolic murmur along the left sternal border, decreases with Valsalva. So what would be the what is the diagnosis and what would you do next? I think in this particular question, the choices were do an echo, chest X-ray, do nothing, and I don't know what the fourth choice was. So typically this would be a Still's murmur, 18-year-old with just 2/6 systolic murmur, which decreases it decreases with Valsalva, so that is flow dependent. This is anytime they start with a routine clinical routine exam, yearly physical, so otherwise healthy women, it's usually nothing to do. So this was actually a Still's murmur, no follow-up required. So Hookham will worsen with Valsalva. And also, when you take your boards, oftentimes you'll have these questions where, they want you to, be judicious in your utilization of resources. So you'll always have questions where you choose nothing as the appropriate answer. And anytime they have a major condition like Hookham or VSD, you'll have a lot more clues in the history to kind of point you in that direction. It's not going to be anything subtle. So a few more questions here. 30-year-old white male, tall, thin, long arm span, presents with acute chest pain, and chest X-ray shows a widened mediastinum. So what is the likely diagnosis? Accident. So the the choices here are what is your next step? Would you do an echo, a CT scan, ultrasound, check troponins? So what's the next step here? Perfect, CT thorax. CT thorax, and then you call the surgeon. Good. So this question here, a young female with several weeks of progressive dyspnea, elevated JVP, leg swelling, what is the next test? Actually, this question was in my recertification boards a few years ago, 3 years ago. So let's see what the group comes up with here. I don't know what the right answer is. I just guessed something. Let's see what you guys all think. Echo, echo, echo. I think I agree. That's what I answered, and I hope I'm right, because it's, you can see clinically that this person has heart failure, elevated JVP, shortness of breath. Amongst all the tests here, I think echo would be most diagnostic. So that's what I answered. Good job. Yeah, we're all thinking alike here. All right, 25-year-old with a viral URI presents with sudden dyspnea and chest pain, elevated JVP, hypotensive, clear lungs. What is your next test? Good, yes. I mean, yeah. So the most important next test would be echo for a pericardial effusion, and I'm sure this person will get an EKG as well. So so you got the echo. So what is your next step? What would be the treatment of choice here? Perfect, yes. So with the available information, you cannot really determine what the treatment is unless you know what their hemodynamics are, which we don't say here. But most of these patients, when they come in with a viral pericarditis, you would usually start with NSAIDs, colchicine as well. And someone like this, if they have a big effusion, you watch them. If they are hemodynamically unstable, then you would do a pericardiocentesis. So for that, they will give you the blood pressure and see what if there's a pulsus paradoxus or not. If there's a pulsus, then you will have to tap it. Okay, moving on to Swan-Ganz. Again, we don't do this very often, but you need to know how it's done and how to interpret some of these. As you know, that's the yellow thing is a catheter that's going from the arm. If it came from the femoral vein, it'll be at the bottom here. So you go through the RA, tricuspid valve, RV, pulmonic valve. You're going into the main pulmonary artery, then you branch out to one of the branches. Ultimately, you go to a small arteriole, and there's a little balloon there that we inflate. There's a transducer at the tip of this catheter. So it measures the pressure distal to the catheter because the balloon kind of excludes all the area behind the catheter out. So only pressure measured is of the arterioles, which would be the same pressure of the left atrium, which would be the same pressure as the left ventricle as long as the mitral valve is open. So the LV EDP or end diastolic pressure would equal the left atrial mean pressure, which would equal the wedge pressure. So that's the whole theory behind this. Now, when you have a catheter here, there are multiple transducers in this catheter too. So you could get the PA pressure. There would be a transducer here, one in the RV, and one in the RA as well. So they're all spaced about a certain distance apart. So you can measure everything simultaneously as well. And usually they also have a temperature transducer here. So using thermodilution, you can measure the cardiac output periodically. So anytime you have a Swan-Ganz question, you could have all these data points that you need to know how to interpret. So this is what the waveform actually looks like. In my boards, they actually showed one of these and they put a mark on where this area is and they want to know what that is. So the choices are RA, RV, PA, or wedge pressure. So you need to have a kind of a general idea of what these things look like. So the RA pressure is always going to be the lowest. It's usually less than 5 to 10 millimeters mercury. And near the baseline, the RV, as you know, goes up to 25, 30, and the end diastolic is closer to the RA pressure, which is 5 or so. The PA would be more like systemic at the lower level, so it'll be more like 40, 20. And the wedge is going to be anything from like 4 to 12 is normal. So it'll be a little higher than the RA pressure. So as long as have a general idea, you can get this right. These are easy pickings. So again, RA, RV, PA, and PCW is pulmonary capillary wedge pressures. And here they show you where the catheter is for each of these positions as well. So this is just what the normal numbers are, which I just went over. You don't need to know these. I think these are all, you don't need to memorize these. These are all available during the boards. Okay, and just moving on. So hemodynamics of shock. This is something you should know. So as you, based on the Swan-Ganz catheter readings, as you know, hypovolemic shock, your preload is going to be low. There's just no volume and hemorrhage, so your wedge pressure will be low. The cardiac output, depending on the contractility is increased, but I don't think this may or may not be accurate. I don't think your cardiac output would be necessarily high because you have no volume. But the contractility is definitely enhanced. So your ejection fraction would be high, but overall volume might be low. So the body compensates by clamping down. So your systemic vascular resistance or the afterload increases. Now in cardiogenic shock, on the other hand, your preload is elevated. You're trying to hold on to volume. Cardiac output is low and your vascular resistance is elevated as well. Anytime there's low blood pressure, your SVR goes up. With the exception of distributive shock, which is either sepsis primarily or thyrotoxicosis, things like that. Your wedge is also low, your cardiac output is high, and your SVR is low. So treatment here would be pressors and fluids. Now, if you have any questions, if you want me to stop or go slow, please just put that down in the chat box. I'm going through some of these things because I presume you all know all these. It's just more of a revision here. So in my boards, we had one of these questions where they gave you a table with all this information, and you had to try to match it up with the different conditions. So let's see. You can take a minute to go through these. So this is the RV pressure, PA, the wedge, and cardiac output increase, decrease, no values there, systemic pressures, and the SVR. Which one of these represents constrictive pericarditis or tamponade? Both would be similar. Let's call 1, 2, 3, 4, 5. Those are the 5 columns there, or 5 rows. So anytime you're looking for constriction or tamponade, you're looking for equalization of pressures on both sides, basically the RV and the LV. The LV would be represented by the wedge pressure. So if you see the RV end diastolic and the wedge pressure equalize, it's called equalization of pressures on both sides. You're right. So someone said C, that's perfect. Yeah, row number 3. So cardiac output is decreased. The wedge pressure is almost equal. The PA mean is about 30 as well. So everything equalizes. So that's typical of constriction or a tamponade. Okay, septic shock. So what would you look for in septic shock? So because you'll have hypotension, SVR goes down. Correct. D would be septic. Perfect. So the SVR is quite ways down. The wedge is going to be really low. And all your pressures are kind of low and your cardiac output is increased. Perfect. Cardiogenic shock. So for cardiogenic, we look for high LVDP, high pressures. Perfect. It's A. So your wedge is elevated. Right-sided pressures are kind of elevated as well. Cardiac output is decreased, and your SVR is increased. Good. High output heart failure. So high output heart failure would be your cardiac output would be increased. So it's going to be either this B or D, and right? And in high output failure, your wedge is going to be low as well. So this is likely the high output failure state where the SVR is also lower, slightly lowered for whatever causes the high output failure typically lowers your SVR. So that would be, and pulmonary hypertension. There's only one left. So yeah, E, the last one is correct. E is pulmonary hypertension. Your PA pressures are high. Typically in primary pulmonary hypertension, your wedge is going to be really low or normal. So if it's more than 16, that's a cutoff. It cannot be considered primary pulmonary hypertension anymore. It's probably a secondary hypertension. Excellent. Thank you. And this SBP is a typo, obviously. So I think you guys will all get this, but this is definitely a real possible questions for the board. Easy pickings again. Okay, a few more questions here. 3 days post-MI, acute shortness of breath, hollow systolic murmur. Swan-Ganz readings are provided. Basically, there's no step up in oxygen while the wedge is elevated. So in the exam, the way the question would be asked is they'll give you the oxygen saturation in the right atrium, right ventricle, and pulmonary arteries. So if there's a step up in oxygen between, let's say, the low RV and the PA or high RV, it means that there is some mixing going on there between the right and left side. That's what that means. So this was, again, an actual question in the boards as well. So what do you think is going on here? Perfect. Papillary muscle rupture. So it's wide open MR. So acute, it's probably inferior wall MI. So they have, basically flash pulmonary edema, heart failure, acute mitral valve regurgitation. Right. So this would be a surgical emergency if you don't treat them. They usually decompensate within a couple of days. So they need to be taken to the OR right away. And what the next test, if they ask you for what test to do, would be an echo. I'm sure you know that. Next one. So acute inferior wall MI with increased JVP, clear lungs, very low wedge pressure. There's a steep wide descent, which is usually an RV infarct. So anyway, so if you have acute, I'm sorry, the answer came out with the question here. So one other thing that can happen with the RV infarct is you could have, with the inferior wall MI, as you know, is RV infarct. So that usually presents with the right-sided failure. So you have clear lungs, increased JVP, low wedge means that the LV is doing okay. So this is typical of RV infarct. Just keep that in mind. So you have a low LVEDP of 10, but a wedge is elevated at 30. So when you see something like this with a big difference, what do you think is going on here? There's only one condition that does this. So as we talked before, the wedge pressure is a pulmonary capillary wedge pressure. It's usually reflective of the left ventricular diastolic pressure as long as there is no correct mitral stenosis. Perfect. So you'd have enough clinical history, but when you see a mismatch between the LVEDP and wedge, that's the only option. Good. Wedge pressure 8, pulmonary artery systolic pressure is 80. So what is your diagnosis here? Pulmonary artery hypertension, primary pulmonary hypertension. So I think for this, they ask you, they'll give you a little blurb on the history, and they want you to distinguish between what is the different types of pulmonary hypertensions. So this would be a primary or type 1 WHO classification. Okay, good. So moving on to lipids. So the most recent guidelines were from 2018. I think that's what we have been following. There's nothing since then. So I kind of summarized everything before. I have all these slides, but I think that's a waste of time. I'm just going to give you the take-home points here. Secondary prevention. So in people who already have had an episode of ASCVD, it's pretty straightforward. The recommendations of a maximal tolerated high-intensity statin. The goal is at least a 50% decrease in LDL. If you don't get a 50% decrease in LDL, then you add Zetia, or you and then you could add a PCSK9 inhibitors as well. That's for everybody. Now, high risk CVD, I have the things that constitute high risk in the next slide. Basically, at least more than one event, so a second event, or just one event with multiple major risk factors. So you got to treat them besides a high intensity statin. You got to do whatever it takes to get the LDL to less than 70. If it is more than 70 with just statins, then you have to add Zetia and or a PCSK9 inhibitor. All right, so 70 is the key number here for high risk. Now, in anybody with the LDL of more than 190, you use a high intensity statin. This is not just for secondary, even for primary prevention, right? That's easy. LDL more than 190 have to be treated no matter what, as long as they're over age 18, 18 or 21, depending on which guideline you look at. All right, so the secondary prevention is pretty straightforward. The primary prevention is where things get a little bit confusing. So I kind of simplified it. This is all you need to know for the boards. So primary prevention is just for ages 40 to 75, right? Secondary prevention is for everybody over age 18. Primary is just 40 to 75. And for people with LDL more than 70. So LDL less than 70, there's no primary prevention strategy there. All right. Now, if they have diabetes, then they qualify for a statin straight away, right? So 40 to 75, more than 70 LDL plus diabetes equals statin. Now, if they do not have diabetes, then you have to do the risk scoring. So you do the ASCVD risk score. If it is over 7.5, then you have to start a statin, typically a moderate intensity statin. Now, of course, they say you got to discuss the risk and benefit with the patients as with everything else. Now, if the patient says that he's not sure, he wants more evidence, then you could do a calcium score. That's the only time you do a calcium score, is when someone has a risk factor that's kind of in the intermediate range and they're not sure if they want to take a statin. Then you do a coronary calcium score. The coronary calcium score is more than 100, you definitely do a statin. Less than 100, then you again, it's kind of ambiguous. They're not going to test you on that, but it's ambiguous on whether you start a statin or not. All right, just to recap, primary prevention 40 to 75, LDL more than 70. With diabetes, you get a statin. No diabetes, you do your ASCVD risk score. If it is low risk, leave them alone. If it's intermediate risk, they get a statin. If it's high risk, they get a high intensity statin. So intermediate is moderate intensity. Now, these are the risk enhancers. So the risk enhancers, you don't need to memorize all of these. It'll be pretty apparent there. So LDL more than 160 is considered a risk enhancer. Metabolic syndrome, CKD with a creatinine of more than 2. Anyone with a history of preeclampsia, which is a marker for future ASCVD. Premature menopause, I don't know what the cutoff for that is, but it's there. Chronic inflammatory conditions, so here you think lupus and rheumatological conditions. CRP, elevated CRP of more than 2. Elevated apolipoprotein, I don't think they'll ask you these because we don't check them here. The insurance companies don't pay for it. Any ABI index that's abnormal, or triglyceride more than 175. You don't need to memorize, but this is kind of what the list is. It would be pretty obvious in the boards when you get these. So basically, whatever I summarize is what is in these tables. So I'm going to skip them. So this is another board question. So these are the groups that benefit from statins. So they'll give you a whole bunch of scenarios, and they'll ask you to choose which one of these groups would benefit from statin therapy, or which one of these patients would benefit. So anybody with the history of clinical ASCVD, so that's secondary prevention, as we talked about. LDL more than 190 for primary prevention, and diabetic with the LDL more than 70. Or risk factor, no diabetes with the intermediate risk factor. Those are the 4 groups. You need to remember that. Okay. The next, another potential question is, so any cardiovascular disease, correct? So any ASCVD, right? Atherosclerotic cardiovascular disease. ASCVD includes cardiac disease, stroke, AAA aneurysms, carotid disease, PAD. Kind of all that falls into that broad group of ASCVD, both cardiac and vascular. So benefit of statins. So this is something that you can be tested on. So statins decrease cardiac mortality. They also decrease all-cause mortality. So that's important to know. They reduce LDL by around 50%. They can increase your HDL by 10%, and they also have pleiotropic or plaque stabilizing effects. So here the question will be, the following are well-described benefits of statins, except, and then you have to choose which you don't think is a benefit of statin. In terms of adverse effects of statins, the ones that are well documented are myopathy, and myalgias are very common, and liver dysfunction. So up to a 3-time increase from baseline is considered acceptable. You could continue statin therapy. So they'll give you a patient who was started on statins and the AST, ALT bumped up a little bit. They'll ask you whether you need to stop the statin or not. So as long as it's less than 3 times, you continue the statin. So the one other thing to remember about statins is there is in observational studies, there's a tendency towards increased incidence of diabetes in people who take statins. Now, some people theorize that it's because these folks live longer on statins that they have a higher incidence of diabetes, but it is not a well-proven, it's not been seen in any of the randomized controlled trials, only because we never follow these patients that many years. We get this data from other registry and long-term registry like the Framingham Heart Study and so forth. So I don't think they'll quiz you, but that's something to keep at the back of your mind. So diabetes, yes. Cancer and dementia are not, they do not increase with statins. So in terms of other lipid therapies, so there is really no known effective medical therapy for triglycerides, HDL, apolipoprotein, LP(a), and all those things. So there are 2 drugs that are in clinical trials for lipoprotein(a). So I don't know if they're going to show benefit or not, but you never treat these with any medications currently. Yeah, niacin has no role to play. If you see niacin, stop it. We use fibrates only if triglycerides are over 500. And that's because there's increased risk of pancreatitis with triglycerides over 1,000. So you start attacking it at half that level. Now, fibrates can cause gallstones, remember that. And also, when you combine statins with fibrates and or niacin, there's increased toxicity, especially liver toxicity. So you have to be careful about combining them together. What is the first treatment for elevated triglyceride? Let's say you see a triglyceride level of 300. What are you going to prescribe? Not for triglycerides, no statins for triglycerides. What else? Something over the counter? There you go. So fish oil. So you could do one of the fancy new fish oils, which is very expensive and not covered. You could just, I don't think they're going to ask you specifically for that. Either omega-3 fatty acids or fish oil would be the answer. The therapeutic dose of fish oil is 4 to 16 grams. So it's a large dose. If you see them give anything less than 2 grams, then that's not the right answer, especially if it's for triglycerides. The board does do these things. In the questions, you'll have some medications that might seem appropriate, but that would be at a wrong dose. So never choose the correct medicine at a wrong dose. That's not the right answer. So fish oil, typically I start at 2 grams and then you escalate it, make sure they tolerate it okay. The only side effect with fish oil is usually burping and flatulence. All right. Okay, moving on, metabolic syndrome. I know you guys all know what this means, but this is still the current criteria for metabolic syndrome. Blood pressure over 130/85, fasting sugars more than 110, weight circumference of more than 88 centimeters. I think it's for men. I forgot what it is for women. Working at the VA, you kind of focus so much on the male veterans that you forget everything else. So triglycerides more than 150 and a low HDL less than 40 for men and less than 50 for women. See that I wrote it down. So know this. So this is how you diagnose metabolic syndrome. You could be quizzed on this. You should know the criteria. Okay. So moving on. So aspirin for primary prevention. So this has been kind of controversial. So there are 2 different guidelines. One is from the USPSTF, which is what the internal medicine boards go by. So based on the USPSTF guidelines, the only people who qualify for primary prevention with aspirin are men and women between the ages of 50 to 59 with a more than 10% 10-year CVD risk factor. So nobody else qualifies for it. People that are in their 60s, it's a grade C recommendation. You have to talk to them about pros and cons. So I think at least in these days, if you have a question of whether you use aspirin or not, almost always the answer is going to be no, because I think they're trying to, because this is a recent change in treatment patterns. We were giving aspirin to everybody in the last few years. We have been asked not to do that. So that's what they're going to test. Now, you want to make sure that you first distinguish between primary and secondary prevention. So if anyone has ever had any event, then that becomes secondary prevention, and their aspirin is indicated, irrespective of age or anything else. Everybody gets aspirin if they've had a CVD event. Now, the ACC/HA guidelines are a little different. They're more broad-based. They say between age 40 and 70 with higher risk, with not high bleeding risk. So it's a very vague recommendation. I just threw it in there just so you're aware of the controversy, but you don't, as long as you remember the USPSTF for board's purposes, you'll be okay. Okay, moving on to hypertension. So this is another area of, just a lot of chaos here. So these are the agencies that have come out with guidelines over the years. That's how crazy this is. Currently, the most recent guidelines are actually from the American Association of Family Practice, and that's what has been adopted by USPSTF as well. So we'll kind of go over that. I think that's what you're going to be tested on. Now, the reason I put the SPRINT trial is this is one of the major hypertension trials, and it was a pretty well done trial with 10,000 patients. So the premise here is they were testing super intensive medication therapy to bring your pressures to less than 120/80 versus following the then guidelines, which was less than 140/90. So 140 versus 120, there was a good 25% decrease in cardiovascular events in folks who are in the intensive treatment arm. So ACC guidelines are based on that. So they really are more aggressive than the European guidelines and USPSTF. So we'll just go with the less aggressive guidelines here. So how to take bloods? How do you check blood pressure? So this is actually a pretty good slide. They can test you on that. So quiet room, empty bladder, that's key. Patients have to be relaxed for 3 to 5 minutes, and you take 3 measurements at 1-minute intervals. And then you average the last 2 measurements. So that's how you check blood pressure for anybody, even in your practice. The arm should be, the cuff should be the correct size, and it should be just above your elbow, so you can fold your elbow or flex your elbow if you want to. That's basically how you do it. So the key is to take 3 measurements and average the last 2. So this is basically this is a current normal. So by most guidelines, the normal is 120/80, and now this is where and anything over that is considered elevated. But based on JNC and AAFP, they start over 140, but ACC starts at 130 as stage 1 hypertension. I don't think they'll quiz you on that, but that's something to be aware of. The key is that you have to average at least 2 readings, obtained in 2 different occasions to estimate at least initially to diagnose. You need to have 2 different office visits and 2 different readings. Now, the other star point here is how often do you screen? Age 18 to 39, 3 to 5 years, over age 40, every year. All right, so they did quiz me on this in my recertification boards on how often you screen these folks. So remember that. Over age 40 is every year. So this is more, the reason I have this slide here, let's go with the left side. So this is just for a kind of FYI kind of slide. So these are the 2 cutoffs you currently have. The ACC cutoff is anybody over 130/80 should be treated, and the USPSTF is 140/90. And you can see the number of people that would actually qualify to be treated. It's just incredible. If you're in the age over 75 age group, by these guidelines, almost 85, 90, 80% of the population would qualify as hypertension and need to be treated. Which is kind of odd. Anytime you have such a large segment of the population have a certain condition, you wonder if if you're being too aggressive with the normals, maybe the normals are a little bit higher than what we're calling it. So that's the whole reason for that slide. It's just a FYI. It's not going to be important in exams. Now, moving on to this side, this is basically a table showing how the blood pressure correlates between what you get in the clinic, home blood pressure, daytime ambulatory blood pressure, nighttime, and a 24-hour average. So all you need to know here is it's always highest in the clinic. The home BP is usually at least 5 to 10 points lower. It's elevated during the day. When you're sleeping, it's lower by about 10 points, and the average is also lower. So we all know that, but this is just the objective proof for that. And the other thing they asked a question about masked hypertension once, so we never really hear about it. So we know normotensive or normal tension. Sustained hypertension is where you have hypertension in the office and home, everywhere. Masked hypertension it's normal in the office setting and it's elevated at home. So it's rather office, it's normal in the healthcare setting. So we do see this because when you have patients in the hospital here, they have much better blood pressure because they're eating a salt-restricted diet and they're not drinking alcohol. Once they go home, they do all that and the blood pressure goes up. So that's masked hypertension. And we all know what white coat is. So they can ask you the definitions for these things. So in summary, normal is 120 or less. So where you start treating is a little variable. I would usually, I would go with the 140 as the cutoff for starting to treat. You need to have 2 readings in different visits. For people between 130 and 160, you need to rule out white coat hypertension for sure before you treat them. So which means that you make them check blood pressure readings at home and send you or do some kind of ambulatory blood pressure monitoring. If it's more than 160, the ACC guidelines say you have to treat right away. USPSTF says you still bring them back one more time for a second reading before you treat them. So it's something to be aware of. I don't think they'll quiz you on that. The goal by all guidelines is to treat for less than 130. Diastolic hypertension, there's nothing in the guidelines currently on what to do with that, so they're not going to quiz you. So to summarize, normal is 120 by 80. Anybody borderline 130 to 160, rule out white coat hypertension, and you treat to less than 130. So that's kind of the takeaway point here. So this is, I've just summarized it in the next slide. So lifestyle changes, right? You have to do that for everybody, no matter what their blood pressure is. But this is the magnitude of benefit that you get from that. So you low salt diet, which is less than 2 grams, you maybe 5 to 8, 2 to 8 is the drop you get. DASH diet, which includes basically, besides the low salt, high fiber, vegetables and fruits and everything. So it's a little, gets you a little bit more bang. Exercise is probably the most effective. You get up to 10 to 15 millimeters mercury decrease if you just exercise 30 minutes a day. Cutting down on alcohol also decreases, and weight loss is more permanent. Every 10 pounds, it's usually 10 equals 10. So every 10 pounds drops your blood pressure by 10. So where this comes into play is you will have someone with a borderline elevated blood pressure, let's say 130, 140, and then ask you that, oh, if this gentleman starts working out 30 minutes a day, how much of a benefit do you expect to see? So this is kind of the approximate numbers. Okay. So moving on, just a few words about each medication that we use frequently. So ACE inhibitors, you need to know, so enalapril is BID. Just remember that. If you, in your choices, if they give enalapril as a once a day administration, then it's the wrong answer. Everything else is once a day: ramipril, lisinopril, and fosinopril. Now, the precautions to take once you start ACE, you definitely have to look for hyperkalemia. So you have to check a BMP a week later. If someone has bilateral renal artery stenosis, do not start an ACE inhibitor. And you never combine an ACE with the ARB because it causes renal failure. And angioedema is a big major side effect. So patients need to be advised on what to look for. If they have angioedema, they need to come to the ER. They cannot stay home and take Benadryl. That's something to remember. So you'll have a guy who just got started on ACE and then he's calling you with tongue swelling. So what do you do for him? You tell him to come in. ARBs, you primarily use when you have cough with the ACE inhibitor. Now, this is key. If they have angioedema with ACE, you wait for 6 weeks, and then you can challenge them with ARB carefully with the low dose and let them know that they need to stay in town, be close to ER, somewhere where they have access to healthcare. Personally, I don't start an ARB if someone has an ACE inhibitor, angioedema with ACE inhibitor, but these are the guidelines. Moving on to calcium channel blockers, the dihydropyridines, amlodipine and felodipine. Once a day, you avoid if people have heart failure. The biggest side effect with amlodipine would be dose-related pedal edema. So you'll have a patient whom you start on amlodipine, now is complaining of leg swelling. So what do? So typically we have them elevate the leg, give it a couple of weeks, it gets better. And if it does not, if there's significant swelling where they can't get their feet in their shoes, then you switch the drug. All right, so moving on, that's all there is in that slide. I don't think we need to go over this. It's, everything. So secondary hypertension, that's the other topic. So when do you check for secondary hypertension? So new onset or uncontrolled hypertension in adults, all right, or drug-resistant hypertension. If there are more than 4 drugs, that's the key. If they are 4 drugs and they're not controlled, then you have to check. Onset of hypertension at a young age, less than 30, or old age, which is over 65. So between 30 to 65. Or if they have a disproportionate target organ damage for the degree of hypertension that you're seeing. They have accelerated or malignant hypertension, so multiple, hypertensive urgencies or emergencies. So if they have any of that, then you screen for secondary hypertension and then you send them to the appropriate specialist for treatment. So how do you screen? So these are basically the causes. So here the question would be, the following might cause secondary hypertension except. So you need to know which are the conditions that do it, which it's pretty straightforward. The common is probably sleep apnea followed by alcohol consumption, then any kind of adrenal tumors, pheochromocytoma, hyperthyroidism, coarctation of the aorta. You rarely see it, but it's here. Primary hyperparathyroidism, as well as any kind of Cushing's disease, adrenal hyperplasia. So more important is what do you do? What's the workup for secondary hypertension? So you start with simple things, check spot renin aldosterone levels. That'll rule in or rule out any kind of mineralocorticoid excess syndrome. Then you check serum metanephrine levels for pheochromocytoma or a 24-hour urine. Then you do a thyroid studies. In terms of imaging, you look for renal artery stenosis. So that's kind of the basic workup you start with. And then based on your clinical suspicion, you go on to more targeted workup to look for any of these other conditions. Okay. So medications that cause hypertension, there's a huge list here, but the key ones to remember are stimulants, because it could be either abused or prescription drugs, very commonly used, NSAIDs and SNRIs, which we don't use as much as we used to. And some of the atypical antipsychotics like olanzapine used a lot. Immunosuppressants like cyclosporin. So this would be someone who's got a kidney transplant and now is having sudden onset hypertension. So look for cyclosporin levels and cyclosporin toxicity. Those are some of the commonest drugs here. I'm sure there's a more exhaustive list. So moving on, hypertensive urgency versus emergency. This is again key to know. Emergency is there's acute target organ injury like brain, heart, kidney, eye. So those are the 4 things you need to remember. So TIA, stroke, chest pain, AKI, or visual abnormalities. So they get hospitalized, they get IV. So emergency is hospital and IV. Urgency is PO with close follow-ups. Urgency is a systolic more than 180 with some symptoms, including shortness of breath, headache, anxiety, so forth. So they don't need to be admitted. So you'll have a clinical situation, clinical story of someone coming in with high blood pressure and some symptoms. So the key is to recognize what is emergency and what's not. So brain, heart, kidney, eye, you get them admitted, IV drugs, everything else, PO, but they need to come back to the office the next day for follow-up. Okay. So what IV medications can you use? Commonly we use nicardipine, unless they have severe aortic stenosis. That's the commonest drug used, followed by either nitroglycerin or nitroprusside. Nitroprusside, remember there's cyanide toxicity, so you cannot give too much of nitroprusside. You got to watch them. And with nitroglycerin, they could develop tachyphylaxis. So you put them on a nitro drip for a while, the blood pressure comes down first and then starts going back up again. So your question would be, you have someone on nitro, the pressure responded, now going back. So what is the possible cause? What would you do? So you stop the nitroglycerin and do something else, start some other drug. Other IV include hydralazine. The only problem with hydralazine is the response can be unpredictable. So they can drop the pressure quite a bit and then have stroke-like symptoms. So you have to be very careful giving IV hydralazine. The more safe bets are esmolol and labetalol in these instances. All right, we rarely ever use, unless someone, if you have someone with cocaine toxicity, then think phentolamine. That's the only reason this is even here, because it's a pure alpha blocker. So with cocaine, guys, you cannot do beta blockers. You can do one of the direct acting vasodilators. If those don't work, phentolamine works really good. So that's the only time that you would ever use it. I don't even think it's in the formulary in most of the pharmacies anymore. Okay. So this is, again, it's part of the whole, holistic care that we're moving towards. So there are other, the question here, I think it was a couple of years ago. So these are they'll list a bunch of things and then they'll ask you to pick the one that's not beneficial or vice versa. So these are the things that are proven to be beneficial based on multiple trials. So once daily regimen or combination pills work better for better compliance, better blood pressure control. Again, motivational lifestyle strategies. This is about you talking to the patient, counseling them, and so forth. Team-based approach is proven to work. So this basically involves nurse case managers calling patients and finding out how they are tolerating the medications, getting the whole telehealth monitoring, and so forth. And then the other thing that was also proven is system-based incentives. They actually paid patients if their blood pressure came down. I think Kaiser and Kaiser Permanente did that. They gave them $50 that they could get their pressures down, and that really helped. And we do have system provider-based incentives. Medicare pays people, practices more if a certain percent of their patient population have good normal blood pressure readings. So these are the things. Again, everything else is similar to that. Quality improvement efforts based on your medical record auditing really works, like what we do with Epic at Upstate and in the VA. They check your chart and see if hypertension has been addressed and if it's controlled. Otherwise, they ding your performance pay. So these are some of the things that to keep in mind, right? So few other facts to remember about hypertension. So for every 20 millimeter increase in the systolic pressure above 140, your risk of CVA as well as coronary events doubles. All right, so now the lowest risk is around 110, 115, but you should remember the J curve. So if your blood pressure goes much below 110, risk of CVA seems to go up because you just don't have enough pressure to perfuse your brain. Other thing to remember, terazosin, prazosin, all these alpha-1 blockers, do not use them. These were part of the recommendations in JNC like 6, and then they dropped it because they actually increased your cardiovascular mortality. So you never use prazosin or any of these alpha blockers primarily for blood pressure control. Now, clonidine you could use, but the problem with clonidine is that they have a good rebound effect. And it's TID dosing. So if people are not taking it regularly, they could have a rebound effect. So it's definitely a second line agent. The patch is better than the PO. If you have a choice, you should prescribe a clonidine patch. So moving on to some of the secondary conditions. So pheochromocytoma is all the P's, the 5 P's. Pressure, right? High elevated pressure, there's palpitation, sweating, pallor, and headache. So if you see 5 P's, think pheochromocytoma. The easiest test to do would be plasma-free metapnephrines, but it's very expensive. 24-hour urine is cheaper, but it's more cumbersome for the patients. Just remember this key thing for the boards. If you're on levodopa, carbidopa, or tricyclics, you could have a false positive. So you have to stop these drugs, wait for the washout period, and then test. In terms of secondary hypertension, this is probably the only thing they could ask you about. Primary hyperaldosteronism, this is also fair game. Who to screen? Typically someone with the resistant blood pressure, young age is less than age 30, and if you find hypokalemia. So if you have a blood work showing hypokalemia, think primary hyperaldosteronism. It's pretty common. It's very easy to diagnose. You do a spot renin aldosterone ratio, and if that's abnormal, then you have your answer. You can treat it with spironolactone. So this is a easy one to diagnose and treat, and very common. So pregnancy hypertension, again, Alpha methyl-dopa, I've never given it out, but it always shows up in the boards. So you have a pregnant female with hypertension, you start with alpha methyl-dopa. The second choice would be nifedipine or labetalol. Those are the commons, but you could use any beta blockers. They're all class C for pregnancy, so we don't know if they work or not. And you typically have to stop the beta blockers maybe a week or so before deliveries to avoid neonatal bradycardia. All right, I think that was about hypertension. If you have any questions, feel free to ask. So moving on to stress test, this is the last topic I'm going to cover today. So I promise we'll stop soon. So with stress tests, I just threw it in there because they do ask you about pretest probability, just see what to test your knowledge. Right. So Bayes theory, you all know that hopefully. So accuracy of a test is highest when a disease probability is around 50%, right? If the disease probability in the middle, then your test does really well. If you have a very low risk population, you're going to have a lot of high false positives. If you have a high risk population, you're going to have false negatives. So any test is best used when the probability of the condition is intermediate, right? So when you have an ER does troponin on everybody that walks through the door, you have a whole ton of false positives. So then we end up, doing a stress test on all of them. It's a pain. So that's just a classic example. Now, if you have someone with really a classic story and you run the same test, and even if it's negative, you're not going to buy it. So because it's going to be a false negative. So we intuitively use this in our practice every day, but it's just important to know what these actually means in words so you can pick the right answer. So as far as the heart is concerned, the two strongest prognostic indicators are exercise capacity and LV function. So this has been asked many times. They'll say amongst which one of the following is the best predictor of long-term mortality or events? So good EF, it's exercise capacity is 1, followed by LV function. Those are the two best predictors more than anything else. And one metabolic equivalent, exercise capacity, we talk about METs. So this is a number to remember. This has also been asked in the boards over the years. One metabolic equivalent equals 3.5 ml per kg body weight per minute of oxygen consumption. Okay. So stress tests start off, the simplest one is just a treadmill EKG. It's the least sensitive and specific. It's about 60 to 70%, but it's very cheap. It does not tell you the location of ischemia. The only people you use this are those who have normal EKG, who can exercise, and those who have a low pretest probability. So there's always, at least every other year, there is a question where the correct answer is a treadmill EKG. All right, you use this prior to starting an exercise program in anybody. If you have for anybody with any cardiac risk factors, which includes all men over age 40, 45, comes to you and says they want to go to the gym, then you first do the treadmill EKG. The other person you would do this is someone who's young, who's anxious, or whatever reason has chest pain that's atypical, then you could do this because it has a pretty good, negative predictive value. So you rule out CAD and you move on. So the multiple contraindications. One is you need a normal EKG. If it is not normal, then at least for board purposes, you cannot use it. So criteria of a stress test. So they can give you describe a stress test, and you have to say what the next step is, whether if it's abnormal, then it's a heart cath. If it's normal, then you could just optimize your medical management. So you need to know what that is. So the classic criteria for abnormal stress test is a horizontal or a downsloping ST depression of more than 2 millimeters. If it's upsloping, it's considered normal. So just remember horizontal or downsloping, drop in the blood pressure, as well as any kind of arrhythmia, especially ventricular arrhythmia. I should have specified it, ventricular arrhythmia or chest pain. So those are the 4 things: ST segment deviation, drop in blood pressure, VT, and symptoms, chest pain. So that constitute abnormal treadmill EKG. Now moving on to stress test with imaging. So you're combining a treadmill with either nuclear or echo. The sensitivity and specificity goes up from 60, 70 to up to 90%. They also give you the location of ischemia as well. The key thing to remember here is target heart rate is not reached, the test is not valid. So do you guys know what the target heart rate is? What is the formula for that?
220 minus the age.
Perfect. 220 minus age is the max predicted heart rate. The target is 85% of that, right? So you have to know that so you can calculate it and you can determine whether the test was valid or not. Now, once you decide you need imaging, you could either exercise is always the first choice if the person can exercise. If they cannot exercise, then you use pharmacological agent, either dobutamine or nuclear. All right, so these are the various combinations I have here. Now, there are other tests that came and went and are not really being used, but they can show up on the boards. So that includes adenosine MRI, PET-CT, dobutamine SPECT, adenosine echo. These are usually not the right answer. What we use day-to-day practice here is going to be the right answer, which would be dobutamine echo. The SPECT can be the LexiScan. LexiScan is the agent we use, like adenosine, it's ragadenosine. And SPECT is the actual nuclear scan method protocol that we use. Single photon emission computed tomography. Right. So they'll never ask you to choose between a dobutamine and a nuclear, but if they do, there are a few things to be aware of. For nuclear stress tests, because it can cause vasospasm, bronchospasm, it should be avoided in patients with asthma. It can also slow your heart rate down. So if someone has a heart block, you want to avoid it. Most importantly, it is a good amount of radiation. It's anywhere from 6 to 15 millisieverts, which is a lot of radiation. So if you have someone very young, especially women, you don't want to use it. All the radiation is right behind the breast, so you don't want to do that. Try to avoid it. So dobutamine, the relative contraindications would be atrial fibrillation because it just increases your rate and you reach target without a contractile response. Any kind of history of VT or PVCs, any hypertension because the dobutamine increases your pressure, you can't use it. CVA or a large AAA or any AAA for that matter, because your blood pressure goes up. You don't want that happening if you have a AAA or CVA recently. Any valvular disease like aortic stenosis is primarily what this refers to. Severe critical aortic stenosis, you should not be doing a stress test to begin with. You don't want to be doing dobutamine. Any bundle branch block affects the septal motion, so it's hard to assess the echocardiographic response. In these cases, you would prefer the nuclear, but again, that's more like a cardiology board level question. As long as you know AFib, VT, severe hypertension, I think you're good. So myocardial viability. So this just tells you if there's any hibernating myocardium. There are 4 ways to do it. Thallium SPECT, which is nuclear stress test using low dose dobutamine, MRI, and cardiac PET. Now, this is the order of how expensive. Actually, dobutamine is the cheapest, followed by thallium. MRI and cardiac PET are really expensive. The cardiac PET is most accurate, but it's very expensive. So if you want the most accurate answer, then you do the cardiac PET, which is done at most of the large centers. Upstate does not do it, but we do have MRI. So other diagnostic tests, I don't know if they'll necessarily ask you. I think it was in med studies, so I put it down here. Cardiac sarcoidosis, the diagnostic test for that would be MRI, not even a PET. Actually, combination of MRI PET is what we use to treat before we start treatment, but MRI would be the initial test. Now, amyloidosis, if you suspect cardiac amyloidosis, ATTR, there's now a treatment which is actually remarkable in the last 2-3 years. I have a few patients on it, and they're doing well. Most of them would have passed away within 6 months of diagnosis, but one of them is now doing okay after 3 years. So it's really amazing advanced in therapy. It does cost about $500,000 a year. It's very expensive. So this is the diagnostic test. It's a pyrophosphate scan, in case they ask you. So typically, just a regular echo would cover most of your needs. That's the commonest answer if you have that as a choice. TEE is only used pre-cardioversion to look for clot and to look for endocarditis and other valvular abnormalities, especially endocarditis and mitral valve repair or mitral valve regurgitation pre-operatively to look at the anatomy to determine if it can be repaired or replaced. That's going to be seldom an answer for internal medicine boards, but something to be aware of. So how do you choose a stress test? The first thing is, can the patient walk? If the patient can walk, then you want to do a treadmill. If they cannot, then it's some pharmacological. So if they can walk and it's low probability, then you do a treadmill EKG. If it's not a low probability, then you do a stress echo or a treadmill nuclear. If they cannot walk, then your choices are just 2, LexiScan or dobutamine. Again, they're not going to make you choose between the two. Okay, that's basically what I said. So cardiac CTA, it's almost never answered in the boards. It's not recommended for screening. It's just high radiation risk. It commonly popped up in the boards for a few years when this was all the rage. Everybody was doing cardiac CTA. So, now they stopped paying for it, so everybody stopped doing it. So we rarely do them anymore. So the only scan you would do would be a calcium scan to get a calcium score. It's called EBCT, or now they call it just a coronary calcium scan. Either one of them would give you, so I think we talked about it in the lipid section. If you have someone with intermediate probability based on the 10-year risk score, and you want to further risk stratify them, then you do a calcium score to see where, if it's low or high. Anything less in double digits is okay. Triple digits, you got to do something. You got to treat them with a statin. Now, if you have a question where someone gets a calcium scan and the score is abnormal, then there are two things you need to do. If it's elevated, they get a statin therapy. You have to control the risk factors, hypertension, dyslipidemia. The other step we normally do is do a stress test. If they have an elevated calcium score, just randomly done, then and depending on how active they are, most of the times, at least in board questions, they're not very active, then you make them walk on a treadmill or do some kind of stress test to rule out ischemia. Okay. So yeah, we talked about this again. Less than 100 is okay. Anything more than 100, you treat them. You really don't even need to know the 300 cutoff. So cardiac catheterization, just a couple of things to know. No absolute contraindication. What you'll be quizzed on would be this paragraph here about post-PCI complications. So post-cath, if they're low blood pressure, hypertensive, one of two things basically: either they're bleeding out somewhere or they close their vessels. So you got to do an EKG, do a hematocrit, see if they're bleeding. If you suspect retroperitoneal hemorrhage, what is the diagnostic test for retroperitoneal hemorrhage? What is the next test you would order? So you would order a CT scan, CT abdomen to rule out RP hemorrhage. Okay. The other complications are CVA and renal failure. Just something to know. That's about it. Okay. So a few questions here. So a patient with multiple cardiac risk factors presents with chest pain. They ruled out negative troponin. EKG shows LVH and the TIMI score is 2. So what stress test would you order? The choices typically are a treadmill EKG, a stress test with imaging like echo, or a dobutamine test, or a cardiac cath. So those are the 4 choices. Sorry, the font is so small here. The choices are treadmill EKG, stress echo, dobutamine, or cardiac cath. Oops, sorry. So someone like this here, so this basically, this person has risk factors, so that rules out your treadmill EKG. Also, they have LVH, so it's not a normal EKG. So now you have to do some other stress test with imaging. So your choices are treadmill, treadmill echo versus dobutamine. So as we talked about, choosing between the two, you always choose exercise. So this would be a treadmill echo would be the answer here. So next one is a 55-year-old with asthma and claudication, presents with chest pain. The EKG is normal. So what would you do here?
Feel free to put your answers in the chat too, guys.
Yeah. So this is something where, they clearly tell you that the person has asthma, so you cannot do sorry, I can't hear you. So this is a situation with asthma. You cannot do a nuclear. With claudication, they cannot walk, so you're just left with the dobutamine. All right, so a third one, 32-year-old fireman for a pre-employment physical, normal EKG. So this is someone that you would do a classic situation for a treadmill, plain old treadmill stress test. And last one here, 76-year-old with hypertension, diabetes, peripheral arterial disease, presents with typical exertional angina, rules out has a normal EKG. So here someone has really a classic typical story, multiple risk factors as PAD. This is someone where you would skip the stress test and you go directly for a cardiac cath. Okay, I think I have one more question here before we stop. So this was the actual question here. 35-year-old obese white female with hypertension presents with atypical chest pain. Which of the following is true? So exercise stress test will be highly accurate. Nuclear imaging will increase the accuracy of exercise stress test. She has a high likelihood of significant CAD. Duration of exercise will not be useful in predicting prognosis. Be correct. So perfect. So this is the kind of test you'll see a lot of questions like this on your boards where you eliminate everything. So exercise stress test is never highly accurate. Anytime they use words like highly, these subjective terms, it's never the correct answer. Correct answer would be very objective and precise. She has a high likelihood of significant CAD. I mean, she does not. 35-year-old. And duration of exercise is very useful in predicting, so that's not true. This leaves us with B. So perfect. All right, good. So, all right, so I think I'll stop here now, and we'll save the rest for later. I think we've had enough for the day. Anybody have any questions about the topics we covered today? Please feel free to put it in the chat box. Or you can always email me later.
Thank you very much.
If I guess my screen keeps on freezing, but what I was gonna say.